Yeah, so this is, I think, the second of 4 talks I'll be part of. Sophie won't get totally sick of me by the end of the day. The topic for this session is anxiety, and Dr. Keary is really the expert and is going to be talking about it. But what I was going to start with was just kind of how we got to this point, how anxiety became a big topic at the conference. If you go, anyone's at the clinic session yesterday, we mentioned that we started seeing kids in 2008. So it's been about 9 years now that we've had the clinic open. And when I say kids, I mean all ages. I call our 45-year-olds kids, so kids and adults. But we started off, it was mainly seizure-based because it was mainly just me at first, and that's what I do. But it became clear as time went on that seizures are really hard to treat if you're not treating the GI symptoms and the anxiety and the sleep. And so we just kept expanding over time to include more specialists to really kind of treat every issue, because if you don't treat one, it worsens the other. If you're too anxious, you don't sleep. If you don't sleep, your seizures are worse. If you're seizing more, you get more anxious. So, it's just this awful cycle. You throw in constipation into the mix, and it just becomes kind of a mess. So you really have to treat everything to keep everything else in check. And one of the things that just kind of started popping up more and more was anxiety. In some cases, it's easy to spot and say, oh, that's clearly anxiety, and then we kind of know what's going on. In other cases, it's not so not so obvious that it's anxiety, and that's when we really started to kind of focus more and more on behavioral stuff. It's not always easy to figure out anxiety. When Ann Wheeler gave an excellent talk. She's a neuropsychologist at the Carolina Clinic, and gave a really good talk at the scientific symposium about anxiety. And one of the things that came up was whenever there's hitting and scratching, is that always anxiety? And it's not. It can be just excitement. It can be frustration over communication. It can be an attempt to communicate, or it can be anxiety. And we started noticing we started figuring out that when certain things didn't make sense and there was no good reason for it, it was probably anxiety. One of the best examples was we've had, I want to say, at least 3 adults now that would just vomit for 24 hours and just nonstop, just vomiting, always end up in the ER, always end up getting IV fluids, and nothing worked, and did these extensive GI evaluations, endoscopies, colonoscopies, the whole bit. And the first clue was talking to one of the families, and his mom said, well, could this be seizure? Because one time we gave Ativan and it really helped, and which was a great point. But Ativan does 2 things: it helps seizures and it helps anxiety. So we just immediately put him on Valium, kind of as a test, and the vomiting stopped. And so then we started treating others with anti-anxiety type medicines, and really just stopped the vomiting. So it's at the last session, there was a question about a teenage girl that was having terrible GI issues during periods, and that's probably the periods causing anxiety. And when you're anxious, if you think about when you're anxious and you're scared, your heart goes fast, you sweat, the whole bit. That's what we call the sympathetic nervous system. And I know those that were last session heard this already, but that's your sympathetic nervous system, and that's what gets your heart rate up. It's what gets your pupils dilating. It's what gets everything running. The other half of the part of the nervous system that you can't control is the parasympathetic. And when the sympathetic is up, the parasympathetic is down, and the parasympathetic part is what controls digestion. So when you get anxious, you get more constipated. So it's even though you look at it and say, oh, it's anxiety. It's not fun, but it's not a big deal. It is. It worsens seizures. It worsens GI symptoms. It worsens sleep. And when those get worse, then just bad things happen. So that's how we started focusing more on anxiety. We had trouble finding psychiatrists that wanted to deal with the anxiety until we found Dr. Keary, who's been very happy to be helping us. So we're very happy to have Chris now as part of the team, and along with Logan now we have 2 psychiatrists in the Angelman world that are really focusing on it. So that's just kind of how we got here. Just to kind of wanted to give a kind of a little spiel about why we're here talking about anxiety, and based on the attendance, I think it's something that people are seeing at home as well. So that's my little piece. So Dr. Keary will give the talk, and then we'll have questions at the end. Thanks. Okay.
Thank you, Ron. So good morning. My name is Chris Keary. I'm a child and adolescent and adult psychiatrist at the Angelman Syndrome Clinic at Massachusetts General Hospital. I'm really pleased and grateful to be here. It's my first conference. I've had a lot of warm welcomes from people. Thank you. Please come up and introduce yourself to me. I'm still getting to know people, and I'm not used to this weather. It's very hot. It's a little distressing for me. I'm much used to got the fair Irish skin. So please come and introduce yourself, and we'll get through this heat together. But today we're going to talk a little bit about anxiety and Angelman syndrome. And I am going to talk a little bit about a study that we're doing looking at anxiety and Angelman syndrome that's supported by the Angelman Syndrome Foundation. We are really thankful for the support that they've given us to help fund this study, and the support that you all have given through them to us to make this study happen. We're kind of asking for an additional piece of support today, and with any presentation you're supposed to start with something you're hoping is the take-home message, and that is for me that we're still doing the study. The study is still ongoing. It's going to be for about another year, and we're hoping that if you're all able, that you're able to have your loved one participate in this study. The study is going to be looking at anxiety, how severe it is, how frequent, how it can manifest in kids, teenagers, and adults with Angelman syndrome. And we think this is really important study. We think it's important because having a good way to measure anxiety, if it is indeed a problem in Angelman syndrome, and I think most people in this room would agree that it is, having a good way to measure it is a really key step along the way to devising treatment studies. Whether it's a medication, or whether it's a behavioral treatment, or whether it's something that families are already doing that we just want to share to the larger Angelman syndrome world, having a good way of measuring the problem is a key step along the way. And oftentimes those treatment studies are required in order to get insurance coverage for certain treatments. So we think it's real important. So I'm going to try and talk with you about why I think it is that important today. So let's get started. So I'm just going to talk about the structure of the presentation today. We're going to talk a little bit more about how we got interested in this question of anxiety and Angelman syndrome. What are some of the things that brought us into feeling it's important enough to do a study? And then we're going to talk a little bit about what's known about anxiety disorders in general, in the general population, what's known about anxiety disorders in other population groups with a developmental delay of some kind, including some different genetic syndromes rather than Angelman. And then we're going to come back to Angelman, and we're going to talk a little bit more about the study we're doing in more detail and how we're going to be measuring this difficult thing to measure, which is anxiety, in a group of people who don't have the ability to at least verbally express what emotions they may be feeling, although may have a lot of different ways of communicating what they're going through. So that's the structure for today. Let's get started. We're going to talk about how we got interested in anxiety. So if you go into the literature and read up a lot on what was known about Angelman syndrome, you're not going to find a lot on anxiety prior to, I would say maybe 5-10 years ago. Anxiety was not traditionally seen as being a core behavioral manifestation of a syndrome. There are a lot of behavioral aspects of Angelman syndrome that were talked about in the literature with this term behavioral uniqueness that was so common it was used as a part of the clinical diagnosis for Angelman before the genetic diagnosis that's used now was used. This constellation of behaviors, frequent laughing, smiling, apparent happy demeanor, excitable personality, hyperactivity, was such a common feature. But anxiety is really not mentioned here at all. There was a study that was done in 2006, a great bit of scholarship that looked at all of the case studies that are reported, a researcher who was caring for a person with Angelman syndrome and wrote it up, got it published. And in this study, they pulled out keywords for certain behavioral issues that were described in those case studies. So lots of different participants going all the way back to the first study that described someone with Angelman. 64 studies in total, 842 participants. And a couple of pieces came out, really common laughing and smiling behaviors, feeding problems, sleep disturbances, restlessness, hyperactivity, and aggression. I wouldn't treat this as the overall prevalence of how prevalent these behaviors are necessarily, but it gives you a little bit of a sense at least what the research world was seeing when they were talking about behavioral aspects of Angelman. Only one study talks about anxiety. just one. And that was a study by Dr. Clayton Smith, an important study from 2001. She's a geneticist, has done a lot to describe and teach the greater academic world about Angelman. And in this study, she used the term, other behaviors observed were anxiety, episodes of aggression, especially if there was a disruption to routine or changing carers. And these are a couple images from that important study. I think the images are really kind of important because one of the important things about our the clinic that we have, the Angelman Syndrome Clinic, is that we do a lot of education. We try to get medical students, residents, other care providers interested in working and caring for kids and adults with Angelman. We think that's a really key aspect because to a lot of medical students, it's just a fact in a book. We want to make it real. We want to make it something that they're interested in and grow the world of caregivers that are out there for kids and adults with Angelman. So we think the pictures are important to bring it home to learners. So subsequent to that study in 2001, there were a couple other studies that again kind of got at maybe this issue of anxiety is an important issue that we should be paying attention to. There was one study, 250 subjects with Angelman syndrome, and they were looking for traits for autism. They weren't really looking at anxiety particularly, but found this consistent issue in a lot of participants that there was a lot of upset when routine was changed in some way. And then another study out of Barcelona, about 70 subjects with Angelman, where about a third of caregiver participants reported sensitivity to loud noise and really upset when there was unexpected noise. So these are again kind of things that started pushing people into thinking more about anxiety. And then there was an important study that came out in 2014. It included a population of patients. They were cared for at the Angelman Syndrome Clinic at Massachusetts General Hospital, included in this. And it was a phone interview. About 110 participants, largely older people with Angelman syndrome, teenagers, late teens into adulthood. The purpose of the study was really to try and understand what are the medical issues, behavioral issues that come up for moving into adulthood for people with Angelman syndrome. And a whopping 46% of caregivers talked about how they thought anxiety was an issue in their loved one with Angelman. So that's a real big contrast to what was known prior to that in the literature, but was maybe known already for a long time by families, but less known to the greater literature world. Sensitivity with changes in routine, again, something that they found. So how come so high in this population, but not sort of described in previous studies? One possibility is that this was the study participants they looked at were a clinically referred population, so maybe these were people with Angelman who the care that they were getting where they were with their hometown neurologist, hometown care team wasn't enough, so they had to seek out specialty additional care on top of that. So maybe a group of people, even among individuals with Angelman who had bigger challenges, possibly. That might partially explain why the numbers were so much higher, or it could really be that this is something that was being missed by the academic world. Now, while that's a good place to start, there were a lot of questions that were left still unanswered. If anxiety is present, how big a problem is it? So family members may say, well, anxiety is there, but it's small potatoes compared to the seizures. It's not as important as the mobility issues. Or are families really saying, this is a major issue and we need to focus on it? If it is there, how pervasive is it? Is it coming up constantly every day, or is it really only specific to certain situations? And are families describing anxiety, or is it something else? Is it the hyperactivity? Is it other behaviors? Is it other issues that are getting mistaken as anxiety, which can be a real challenge sometimes to parse out what's what. So we felt that these were some of the next steps, but we thought that it was really important. And part of the reason for this was, as Ron brought up, we kind of wondered whether or not anxiety was a part of aggressive behaviors if they were present, or upset or tantrum periods. So there are a lot of things that might be underlying an aggressive behavior of some kind. It could be that it's not even really aggression in the traditional sense. I feel like I've worked with a lot of people who they're expressing affection and it's kind of like a rough hug, or there's a real like enthusiasm and excitement to see a loved one, or it's an act to get the attention of a loved one. maybe different than when we think about aggression in the traditional sense. It could be that it's an attempt to sort of express your frustration or communicate that you're in pain or communicate that you're not happy about something or that you want something. But it could also be an escape behavior to get away from an anxiety-provoking situation or a way of expressing being anxious over something. So we felt that there were a lot of potential downstream effects if you could address anxiety. And issues like aggression, issues like anxiety can really impact the educational opportunities that you get, the ability to have a full range of experiences in going to the restaurants, going to movies, all sorts of little things that make up whether you have a full life and get to have a wide range of experiences that can get in the way. So we felt it had very important quality of life implications. We began to observe over time people that had the onset of behaviors that looked like anxiety later on in life. It wasn't present when they were younger, but moving into teenage or adult years, it started to come on. I had one family member tell me that she loves her son with Angelman and all aspects of who he is, including his Angelman, but these anxiety behaviors, these are not my son. And that kind of suggested to us that this is not something that we should necessarily be saying comes with the territory in Angelman, but rather be a separate issue that can be treatable. So this is why we thought it was important. So now I'm going to move a little bit to the more statisticky part of my presentation where we talk a little bit about what's known in the general population or other developmental disabilities and how this informed our thinking of what we maybe expected to find going into looking at people with Angelman. So in the general population, anxiety disorders are common. They're the most common form of, as it's called, a psychiatric diagnosis. And there was the big studies that looked at prevalence rates in the population, article put out in 2005, identified a whopping 18.1% of adults with anxiety disorders. That may feel like a really extraordinary number, and it kind of is. That includes phobias, so things like arachnophobia. I'm not a big fan of spiders myself, or fear of heights, things like that. So that probably pushes up the number some. But phobias, social anxiety, most common types of anxiety in the general population in adults. Among kids, there was a separate study that showed numbers were a little lower, although they didn't include phobias. And the highest problems with anxiety in this population were social anxiety as well. Social anxiety is the fear of being evaluated. For instance, the fear of speaking in a room in front of a bunch of people, for instance. Or generalized anxiety has to do more with free-floating anxiety, constant worries about things that come up every day, sort of frequent worriers. And separation anxiety, just what it says in the title, fear of separating from your loved ones to attend school or to go to bed at night. So these are the three most common anxiety disorders in teenagers and kids, with the prevalence numbers there. Somewhat more common in females and males in both kids and then also adults. And so we wondered, are we going to see the same numbers for individuals with a developmental disability of some kind? This slide is a little bit, I hope you can see it okay with the contrast. I've got a little bit of a pointer here. I apologize got to make a choice on which side I use the pointer, but I'll kind of we'll try with this side here. Let's see if that shows up okay. So what this slide depicts is a figure adapted from a study that looked at what is the age of onset for anxiety disorders just among the general population. And what are just the common fears that kids can have at different time periods in their life. And when it's severe, it can manifest as a disorder. We might call it a disorder of anxiety. So anxiety is probably one of those emotions that all of us have. It's normal to have it. It's only when it's severe that we can call it a diagnosis, when it really gets in the way of your life. So these are normal anxieties we would expect kids to have at different time periods. And if you go to, early development at infancy, you can see the challenges that kids have in terms of anxiety at this time period are around separation and around stranger anxiety. And when it's severe, it manifests as a separation anxiety disorder. If we move into later into childhood, we see fears of death and dying, fears of being separated from your parent because of them getting sick in some way or being in a car accident. Fears about thunderstorms, specific phobias, animals that oftentimes come up at this time. And then moving into the school-age kids, we could start to see performance anxiety, fears about whether you're going to do well on that test or quiz, and also, which when they're severe can come out as generalized anxiety. And then also things that can start to present around OCD at this time, fears around germs or getting sick, or concerns about safety. And then when you move into the puberty time period, it's social anxiety. Fear of being evaluated by others, fear of being rejected by your peers. So we thought about this in terms of the normal onset for anxiety symptoms, and we kind of wondered how having a developmental disability of some kind might affect the times of onset. So one theory was if people have cognitive skills that are at a lower developmental time, will we see anxiety disorders from that developmental time? So if that makes sense. So if people have cognitive or certain cognitive domains that are at a younger period of time, does that mean we're going to see higher rates of separation anxiety or certain phobias? And will they be protected against having anxiety disorders at this later time? Will these be lower risk? Or does it have nothing to do with developmental level and has to do more with just the age of your body, where you have the hormonal changes that come with puberty, and that's when social anxiety comes out and has nothing to do with sort of more the developmental level? These were some of the questions that we were asking ourselves going in. Or is it just protective? Are you less likely to have an anxiety disorder of some kind if you have a developmental delay? These are the kind of questions that were going through in our mind, some of the theories that we had. So the next step we had is we looked to studies that have been done looking at individuals with a developmental delay of some kind to see whether or not those were true. So I'll just take a quick minute here to talk about there are many different severities of developmental delay that we might use the term intellectual disability, or old term for this that's not used anymore, mental retardation. But from the mild side, where individuals have speech but have real difficulties with making complex decision making, managing money, things like that, all the way to the severe side, profound side of individuals who need help with all the basic activities of daily living and self-care. So there was a study in 2003 that I want to tell you about. It was a large community sample of individuals, just in a general population. They weren't necessarily seen at a clinic. And this included individuals who were more on the milder side, mild and moderate. And what they found is that the rates of anxiety disorder were higher than the general population, 21.9%, with phobias, very high rates of phobias, higher rates of obsessive compulsive disorder, and comparable rates of social anxiety. So the take-home point from this slide and from this study, we felt, is that it is clear having a developmental delay doesn't protect you from having an anxiety disorder. In fact, the rates were higher. Okay. There were some other studies that looked at a wider range of individuals with a developmental delay of some kind. The first study here, Cooper, 2007, I want to tell you about. This included individuals from the mild side all the way to the more profound side. They found when you included individuals with more significant disability, the numbers of anxiety went down. And then in the more, sorry, I'm going to step back here for a minute, severe and profound sections, the rates were particularly low, 2.4%. And that same thing was found in a separate study. This is the Baumick et al. 2008 study. And that included just individuals with more severe disability, and then the rates were similarly low of anxiety disorders. So can we generalize these findings to individuals with specific genetic syndromes like Angelman? So the finding from those things suggested that higher rates of anxiety disorder, but the more severe someone's developmental disability is, the lower the risk for anxiety. So can we make the same assumption about Angelman? Can we make the same assumption about different genetic syndromes? And for this, to answer this question, we looked at a couple of other genetic syndromes. I'm going to go over these briefly, but then we'll come back to talking about how this applies to Angelman. So Fragile X syndrome, Down syndrome, the most common genetic causes of developmental disability in the United States. There was a study that was done, about 100 subjects, kids and adults with Fragile X syndrome, who can have levels of developmental disability that are on the very, very mild side, learning disorders, all the way to the more severe and profound side. And what they found in this population is a whopping number of anxiety disorders, upwards of 80%, which seems hard to believe, but it's something that's generally understood among a lot of researchers who do research for individuals with Fragile X syndrome, that there is an extremely high rate of anxiety disorders in people with this specific genetic syndrome. And the more severe their disability is, the more presence of anxiety disorders they had, particularly social anxiety, particularly phobias. So the take-home point from this slide is that it may be that certain genetic syndromes are at higher risk for anxiety disorders than others, that we cannot take what is known about either the general population or the general population of individuals with a developmental delay of some kind and say it's going to be the same for every person. Similarly, a separate genetic syndrome called Williams syndrome, that includes individuals generally who have got a mild to moderate level of developmental delay. There were two studies I want to tell you about. One is in kids and teenagers, and the other one was in adults. When they looked at kids and teenagers, similarly, the rates of anxiety were very high as compared to the general population, with almost half of individuals having a phobia, a severe phobia of some kind, and then high rates of generalized anxiety, constant worry anxiety. As you got older, the rates of that generalized anxiety really increased to the point of adulthood where the rates were extremely high compared to the general population. Rates of social phobia a little bit on the lower side as compared to other anxiety disorders that were seen in this population. So, two take-home points from this slide. Here's another genetic syndrome that seems to have a higher risk for anxiety. Also, the risks changed as people got older. As they moved into adulthood, the presence of anxiety disorders increased, suggesting that people with this syndrome, you have to really start watching around the teenage moving into the 20s time period. So are we going to find a similar sort of thing for Angelman? I mentioned here only briefly Down syndrome. There have not been a lot of studies, at least that I can find. I have to admit, I'm not an expert in this field particularly, but I can say that there was one study that was done that found extraordinarily low levels of anxiety disorders in individuals with Down syndrome. High rates of hyperactivity, oppositional behavior, but anxiety levels were far lower than the general population. So this may suggest that some genetic syndromes you may see lower rates of anxiety than you expect you're going to find. Perhaps there's something protective in this case. And then so, before I talk about Prader-Willi, I'm just going to take a quick minute here as a reminder, and I apologize for the people in the room who are already aware of this, or I'm just, as a reminder already, that there are a lot of different genetic mechanisms that can lead to Angelman syndrome. I just mentioned two here. I identified the two potential causes of chromosome deletion and uniparental disomy, and there are other potential mechanisms as well. But just as to show here, so in this case, the mechanism of the development of Angelman came from a deletion in the maternal chromosome in 15, and in this case it came from having two copies of the paternal chromosome 15. So two different genetic mechanisms to get to the same syndrome of Angelman. So I mention that only because, and then there's some evidence to suggest that there are different constellations of medical problems, or different severities, you could say, in individuals with one inheritance mechanism. So higher rates of more severe seizures in people with a deletion mechanism of genotype for people with Angelman syndrome as compared to uniparental disomy, UPD. And then higher rates of potentially improved mobility in people with uniparental disomy as compared to deletion. So if we're seeing medical differences, will we see behavioral differences too, comparing one genetic mechanism to another genetic mechanism? Well, you do in Prader-Willi syndrome. Prader-Willi syndrome, let me just go back for a moment here, sorry. With Prader-Willi syndrome, it's a genetic syndrome that bears some commonalities to Angelman in so much as for Prader-Willi syndrome, the error is in the paternal chromosome 15. So a deletion in the paternal chromosome or uniparental disomy, two copies of the maternal chromosome of 15. So I felt as if it was an important thing to look at for this presentation because do we see differences in behavioral issues between people who have different genetic mechanisms for Prader-Willi syndrome? That's why I'm putting it in this presentation. And that is indeed the case. Individuals with a UPD, uniparental disomy, for Prader-Willi syndrome are at higher risk for certain psychiatric symptoms like psychosis or autistic traits as compared to people with a deletion. So if that exists in Prader-Willi, it stands to reason that there may potentially be similar differences in terms of behavioral issues or anxiety in kids and adults with Angelman. So coming back to Angelman syndrome now, I'm going to talk a little bit about how we wanted to measure this question of anxiety and Angelman and why we think this mechanism is important. So there's one important study I want to tell you about that was done in 2015 by Dr. Wink and her group out of Cincinnati. They did a study of individuals with Angelman syndrome, a wide variety of age here, but a mean age of about a little almost close to 14 years, and 12 subjects with Angelman. And they did a battery of looking at different behavioral assessments. One of them was assessments for anxiety, using assessment tools that have been used before in people with a developmental delay. In their study, they did not find elevation in anxiety. They found elevated rates in hyperactivity, irritability, problems with sleep, but they didn't find elevations in terms of anxiety. So how do we reconcile this finding with the earlier ones I was telling you of there being some significant evidence of anxiety as being an issue and a lot of reports from parents? And you can think about a lot of potential possibilities. One is that maybe we just didn't have enough subjects to really see the anxiety that was there. They sort of have, for the 12 subjects they have, those subjects particularly didn't have an issue with anxiety. It could also be that it's more of an age effect. That you need a larger number of individuals with Angelman participating who are of a certain age. Like if it happens later on in life, we need people who are older to really see that effect. It could be as well that it has more to do with the genetic mechanism, how you got Angelman. So we would see it more in a particular genetic mechanism rather than another's. So this study had a wide variety, included more or less equal splits among different genetic mechanisms, whether it was deletion or a UPD or a mutation. Another possibility is maybe they weren't using the right tools or tools that could be better able to identify anxiety. Are there better tools out there that they can use to really pick up what parents are reporting? So these were some of the things that we thought about. We read this study a lot and thought about it a lot when we wanted to design our study looking for anxiety and Angelman. And we benefited from learning what they learned. I think one of the biggest challenges, and probably one of the reasons why we don't have a study like this, I told you about those studies in other genetic syndromes, 100 subjects or more. We don't have one of those studies in Angelman yet. Why don't we? And I think probably part of the reason is that we are still trying to find good ways to get at the inner emotional state for people with Angelman. And what's a good way to measure that? What's a good way for us to have as much confidence as we can that we're really picking it up and identifying what parents are noticing, what caregivers are noticing. And so what we thought was important was approaching the issue of anxiety from a couple different directions, where we would combine caregiver interview, observation by the clinician who's conducting the assessments in person, and then the use of standardized assessment tools, and using all of them together to try and get at this issue of anxiety. So I'm going to talk about each one of these mechanisms briefly. So when it comes to caregiver interview, there are a couple advantages with using this. So this would be just a discussion with the family member, and the advantage here is that family member knows their family member with Angelman the best. They are the expert in their loved one with the condition. And they can tell you, though, we saw this behavior, but it was constipation before. They can tell you, well, we saw this behavior, but it was a heralding of seizures getting worse. They can kind of distinguish what may be medical issues and what may be, it's never easy. I think I still have a lot of family members tell me that they're not sure, but they can at least draw on their previous experience of what they know about their loved one with the condition. And they can also draw on a wealth of experience to tell you, anxiety happened in this situation. I know that is a situation that brings up anxiety or behaviors that look like anxiety. The challenge is that family to family, they may have very different standards for what's a problem. I guess I sort of learned this by talking with a family member to ask them whether they thought aggression was a problem, and the family member said, no, absolutely not. But when I asked it a different way, how often do you see an aggressive behavior? They said, well, every day. And it highlighted for me how each family is different that I'm working with. Each family is different in terms of what they identify as being a problem. And So that's a challenge for assessing this symptom. You have to kind of, we need a standardized way in addition to families reports. Clinician observation. So the clinician can get something from the observation. We thought a lot about whether we wanted our study to be an assessment tool that's mailed to families, and then they would send it back to us. And that would make it a lot easier to get a good number of participants. And we decided against that. And the reason we decided against that is we felt that there was something important with being in the room and spending time with the individual with Angelman, in terms of us learning about them, knowing who they are, and seeing things that may be present in the appointment with them that might inform us our thinking about anxiety, to get us a little bit closer to like how you would in the clinical care interview with somebody. So things that a clinician might observe would be the signs of anxiety on someone's face, that fight or flight response that Ron was talking about, sweaty, high blood pressure, a leg that's bouncing or finger picking, or all these signs of kind of adrenergic, worked up signs. Signs of excessive shyness, and aversion to new environments or to new noise. There's a way in which just spending time with the family and the individual informs the kind of questions you ask to get at anxiety. This is the same technique that's used by behavioral therapists. Behavioral therapists will head out there and they'll spend time with the individual. They'll go to their school with them, they'll come to the home and they'll observe. And that's how they really develop a good sense of what might be driving the behaviors. So that's a valuable technique as well. And then finally, there's standardized assessment tools. The advantages here is it's a standardized way to measure it across individuals. We've got a way to quantify how significant the problem of anxiety is, and whether or not it's a severe problem, get a sense of the severity of it. We can also then design a treatment study where you have a sense of, if it got better, how much did it get better? Do you see improvement? And the advantages with this is that there aren't a lot of great tools to assess anxiety in persons with Angelman. Even the tools that have been validated in people with a developmental delay of some kind still have an expectation that the participant oftentimes is going to have some verbal expression. So this is a real challenge here. And the tools that do exist may only assess certain aspects of anxiety. They may not get at problems with separation, or they may not get at phobias. So that's a real challenge here. And if you use other tools and you skip certain questions, you're not using the tool the way it's supposed to be used. And you may overestimate levels of anxiety, or you may miss it if you just skip certain questions. So it really is a challenge. But we felt it was important to include all three of these together. And part of the reason why we wanted to get at all three is that we wanted to see how well do these standardized tools stack up when you ask a family member what they think about their loved one with Angelman. If a family member said, absolutely, I think my son is Angelman, what does it correlate with in terms of the assessment tool? Does it correlate with specific medical conditions of certain kinds? We felt it was important to be able to have the three of them together, where we could start to see how well do these assessment tools get at what families are telling us. So that's how we thought it was important. And that's how we're conducting the study. And I think I'll probably, we wanted to make sure we left enough time for questions. How am I doing on time? Okay. So I'll just come to the finishing up point here so we can leave plenty of time for questions. And I want to leave you with the emphasizing again that we think this is a very important question to address. We want to be able to tell families who's more at risk for anxiety symptoms or anxiety issues becoming a major problem. This is one of the most common questions that I get. What can I expect when puberty comes around? What's sort of the challenges that we see as people get older and move on into adulthood from a behavioral standpoint? Can I expect that this is going to get better? We want to be able to have some things to answer those questions. We want, as Ron mentioned, there are some seizure treatments that also really work very well for anxiety. Maybe we want to be thinking particularly about those kind of seizure treatments as also helping for behaviors to minimize the total number of medications that a person with Angelman has to take. And we really think that a good study looking at finding a standardized way to measure anxiety is a key step along the way to designing a good treatment study. If you've got a good way of measuring the problem, then the treatment studies are going to come. and there's going to be more people interested in designing treatment studies, and not just medications, but behavioral treatments as well. I'll leave you with a story that, it's like an anecdote. About 2 days ago, I found myself arguing on the phone with an insurance reviewer for why behavioral therapy was important for a young adult who had Angelman. And what they said back to me was, well, we don't have any research suggesting that it's helpful in Angelman. And it really set my blood pressure through the roof, I'll tell you. I really feel as if people with Angelman can be punished for having a rare disorder and not get the same care that other individuals with a developmental delay of some kind should be getting. I want to be able to go back to that insurance reviewer and say, here's what we found. See, other people may have had this experience as well. So we think it's important. We think it's so important that we brought our research staff here to the Angelman Syndrome Foundation today. And we've got a couple slots. If you brought your loved one with Angelman, we would love to meet them and potentially have them involved in the study. Jennifer, who's a research administrator I work with, is she here today? I will have, there's Jennifer in the back by the water. So if you have your loved one with Angelman here today, we would love to have you come and introduce yourself either to me or to Angelman, to Jennifer after the presentation. And we've got a couple slots available, so we want to kind of prioritize that for families who it would be a hardship for them coming over to the East Coast, and we'd love to have them involved. It's about 1.5 hours to 2 hours of time for the commitment. And maybe we should finish there to make sure we've got time for questions. Thank you so much.
So, hi, Chris. I'm Becky Burdine. My daughter Sophie's 11. So I had one comment for you and one question. So in Sophie's case, her anxiety doesn't manifest as aggression or excitability or anything like that. Her anxiety manifests as if she basically closes her whole world off, so it's about this big. She focuses right on her toy. She won't pay any attention to anything that's going on. So I don't know if that's something you guys might want to look for too, or the kids that completely withdraw to get out of this situation. She's not mobile, so that might be the reason that's been her way of doing it. The question for you guys is, there's a lot of parents in the room, clearly, where this is an issue. What are the treatments that we should be looking at for anxiety? I mean, behavior modification for sure, but do these kids need Lexapro? Do they need, what kinds of things can the parents think about doing?
Okay, everybody can hear me okay through this? The question is what kind of treatments might be potentially helpful for anxiety. While there, like I said, while there are not treatment studies yet, we can't wait until there's treatment studies to try something. So maybe I'll put in a plug for Dr. Wink's talk, which is later on today, looking at potential treatments for behavioral issues. But we've been trying traditional anxiety treatments that we know have been helpful for other individuals of a developmental disability. I tend to find myself using the literature that I have in my mind from what's known in the world of autism, although we cannot assume that it's going to be the same for people with Angelman, because I think they're very different conditions. But I know that antidepressant medications like Lexapro that you mentioned can sometimes cause irritability, especially in younger kids, especially potentially in people with a developmental disability. I find myself oftentimes starting with other medications that have serotonergic effect, like a medication called Buspar or Buspirone, another anxiety medication first, which tends to be tolerated a little bit better and less likely to result in behavioral side effects. Benzodiazepines tend to get used a fair amount, like Ron talked about. That's medications like Ativan, Xanax, Klonopin, medications like that, because they control seizures as well. Mm-hmm. I've definitely seen them be helpful, and they're good for anxiety that may be situational. Those are oftentimes good places to start, but I do find myself sometimes trying SSRIs carefully, low dosage of my fingers crossed, and with frequent check-ins.
Have you seen propranolol? I was asking Ron, have you seen propranolol being used at all?
Oh, propranolol, yeah, absolutely. So propranolol, beta blocker medications, long-acting versions of propranolol, I've absolutely tried, and I've seen that absolutely be helpful. So beta blocker medications oftentimes get used for performance anxiety in people who've got anxiety who don't have a developmental delay of some kind, and gets prescribed a lot, can be really helpful. And that, I really don't see a lot of behavioral side effects, at least in my experience with it.
Yeah.
Alpha agonist medications like guanfacine or clonidine I've used as well.
Yeah, and the propranolol really specifically targets that sympathetic output, which is really kind of where the anxiety gets better.
That fight or flight response.
Yeah.
Thank you.
Yeah, and it's nice too, like having the clinic coordination. Like a lot of times, we use a lot of clobazam, which you'll find out in a few hours. But it's an atypical benzo, but it's not as good for anxiety, but it does have some anti-anxiety properties. So a lot of times I'll get an email saying, can we go up on the clobazam before trying something else? Because whenever we can do 2-for-1 medicines, we do between for seizures and sleep, or for sleep and anxiety, or and there's not many seizure medicines that help with that, but the few that do, we can try to maximize those first before adding a behavioral medicine.
My son developed his anxieties, it seemed, as he became a teenager. And it's like he sort of knows more and understands so much more. And things that he would do as a child, like go to the dentist, and he will not do that now. And he won't even let them do a simple ultrasound on him. Like, he is just totally, you have to put him out for anything that he needs to have done. And it's an issue. I guess medication, might work in those brief tests and stuff, but I don't think he needs medication all the time, because he's usually pretty good, and he's in his environment that he's happy, right? So it's not an anxiety that's around all the time, only in certain situations. So I was wondering if that was one thing. The other thing was, I just wanted to say that if you want more people to participate in your study, is it possible to just do it in the clinics, like the one in Canada and all the clinics in the States, even though you're not there? If you could get information, then you might have a much better population and much more. Is that possible to do? To set it up in all the clinics?
Yeah. Yeah. I mean, it's definitely, so, applying for the grant, getting things started, it's, you just it is much easier to do it at one place, but, if it goes well, which it seems like it really is, then there's always that possibility to expand to a multi-center trial. But you have to start small somewhere, and then if things go well, kind of branch out.
Because I think it's
absolutely, yeah.
It's definitely an issue, and you're not seeing, like you mentioned, you're not really seeing the true numbers, I don't think.
Yeah. Your comment makes me think about situational anxiety or phobias. And people may say, phobias, how big an issue is that? Well, it's a big issue if you need to have regular medical care and you're afraid to go to the doctor's office. That's a major effect on your life. The standardized assessment tools that have been used up until now, measuring anxiety and Angelman, don't get at phobias, or might not get at phobias, or might not get at separation issues. So I share your concern that we're maybe not really getting the severity of the issue for the assessment tools that we're having, and that's why we wanted it multi-different approaches. I like your idea in terms of making it multi-site. The advantage of meetings like this is I get to meet Dr. Wink, and we all get to communicate together and interact with one another and think about how we want to collaborate.
Yeah, and it's in talking about with puberty, that's a great point. A lot of what Chris was talking about was the developmental ages of people and kind of where they are kind of cognitively, developmentally. But kind of no matter where people are, when puberty hits physically, you're 15, you're 17. So now you have these physical puberty symptoms, and you're physically a teenager, which we all know is very, very difficult time. But cognitively you're not, and that disconnect can be really difficult to have that physical puberty and not be able to really comprehend it well.
I had a question about the studies that you did. In that, did you take into consideration the seizure medicines that your Angelman syndrome patients were on? Because, as you said, some affect anxiety, some help, some don't, some add to it. And so was that a consideration when you were studying to see the prevalence of anxiety in Angelman patients?
Yeah, it is a consideration. Anyone, I don't know if there's anyone in the room that's already participated in the study, there may be. It takes some time because we've got a couple different ways that we ask the question. Some are which are in the here and now within the past 2 weeks, and some are lifetime anxiety symptoms. So we're hoping at catching if there are anxiety symptoms later that maybe the seizure medication's addressed. Plus, we're looking at previous treatments and whether they were helpful or not, and we're trying to remind ourselves to ask about seizure medications and to say, did that have any behavioral effect at all? That'd be a really useful thing for neurologists if they knew not only does clobazam treat seizures, but it seems families are reporting it helps with anxiety or irritability. So we're trying to think a lot about that.
Yeah, and with these seizure medicines, it's not, it always it'll come up at the seizure talk. It's not 100%, so clobazam helps anxiety in most people, but not everybody. Other medicines like Keppra will worsen behavior in a quarter of people, but not everybody. So it's, it varies, and so you can never make a blanket statement like, yes, this is the one to use for this is the one, because it's going to be the one to use for most people, or for some people. And I also get a question a lot like, oh, what's the first medicine you use for someone with Angelman syndrome? It's different for everybody. When picking a seizure medicine, you think, you have to pick a medicine that treats those types of seizures. That's number one, but it's usually a pretty decent sized list. So the question is, what side effects would be a bigger issue in this specific person? Is this person sleeping, not sleeping? Are they constipated, not constipated? And then you really, do they need to gain weight? Do they need to lose weight? You look at everything, and then you kind of pick the one that fits the best. And if they tolerate it, then that's one. But sometimes, people just don't tolerate a certain medicine that they really should, and you have to move on. But same thing with anxiety, with any kind of medicine we use, it's even though everyone's got the same kind of stuff, everyone's a little bit different, and you really have to take everything into consideration when you kind of pick that first medicine.
Hi, we met already, but the question that I have is, so the study right now is obviously being done at a clinic on Massachusetts or wherever it's at, right? Would you guys be willing, like my son, he does have ABA services with the behavior, and it opened up a lot of eyes and what may be going on with his anxiety. The question that I have though, would you guys be willing, if I can get somebody to collaborate with the observation piece, if there's no way of traveling, to be able that you guys can have that data? Maybe do the parent interview and then have somebody else that is the BCBA or behavior therapist do the observation piece for those parents that may not be able to travel to be part of that study.
That's a really nice question. I'm really appreciating the enthusiasm that I'm getting here, and it's making me think of how might we be able to get creative. I can't say that for sure at this point because it requires us going back to the Institutional Review Board, IRB, to petition for that. I think that it probably would be a good idea it seems like the most logical thing is to collaborate with other people about trying to get our numbers up, which is something that there's no room for being territorial in this world. We kind of need to work together around this, especially with these few clinicians.
Yeah, especially when I'm seeing, when you guys are mentioning the behavior and seeing him in the clinic doing the behavior therapy, I can see now why the behaviors escalate because of the anxiety of not wanting to go in a room to do an activity or not wanting to be with somebody else because there's too much noise. So that's why it's like the connection. I would love to see the behavior therapist kind of see that, okay, it may not be his aggressive behavior, but it may be his anxiety that is triggering the behavior.
Mm-hmm. Yeah, it's a good point. I think key to this care is oftentimes collaborating with behavioral clinicians, and I think ideally, with our clinic, we're looking to grow it in a way that behavioral consultation is a key part of the care we provide. As a psychiatrist, that makes it a lot easier for me knowing what I'm trying to help with.
Yeah. And before we do another question, I had to point out, I think Eileen will back me up. If we gave this talk 5 years ago, the room probably would have been like barely full at all. It's amazing how many people came to this talk. And I just think it's great that an issue that's kind of this big and this important has come so far. And just, I think I've been involved with ASF for maybe 10 years now, and really things started off with really just very few people, Logan and Jane Summers and others, kind of bringing the issues kind of into light, and then like with the clinics opening up and just seeing it in everyday life, just really seeing it take off. It's like, do you think it would have been this full 5 years? Not yet, no. Would have had like 10 people probably. So it's amazing to see how many people came today.
Yeah, could you talk a little bit about the connection between outside stressors and anxiety? So I'm thinking specifically of like parents getting divorced is going to cause stress for all the children, which may manifest itself in anxiety, or moving to a new house. So number one, how do you control for that in your study? And number two, are Angelman kids going to manifest, are those stressors going to affect them in a similar way as typically developing, or how is that going to be different?
That's a really excellent question. I think every parent probably in this room would say that they think about how to, if their loved one has anxiety, how do you protect them from experiencing that anxiety, and what can you do to help them, and what can you do to prepare them if there is a divorce, for instance. With our study, a lot of the assessment tools that we're using will ask about what are the stressors and what are to what extent the anxiety has an effect on the family, but the extent to which what's going on in the family has an effect on an individual with Angelman. I don't know if we are looking as much at that. I think that is a really important question, especially my experience anyway of working with kids and adults with Angelman is that there is a strong interpersonal connection and a strong amount of cueing to the parent oftentimes, and that almost to a fault, I wonder sometimes whether that feeds into the anxiety in some piece, a sort of a constant need to be close to the parent and how the parent is doing. So I think it's a smart thing for us to be vigilant to, and I think it's an important thing for us to think about, although I don't know if there is a formalized way, to be honest with you, that we're assessing that in the study. But you're bringing up something that I think is really important.
Hey, Chris, can I just add one thing? Hi, I'm Logan Wink. Please come to my talk. We'll talk about a lot of this. But I just wanted to say that absolutely people with Angelman syndrome are going to get anxious when there are big life changes. Absolutely. There is no difference between your typically developing teenager and your Angelman, child. Yeah. So that's something to consider, and then treatment has to be sought around that, just like we would support any child. So I'm happy to talk more about that after lunch.
Yeah. And that's a great point in general. People tend to forget that kids and adults say have Angelman, but they're still kids and adults, and they do the same things that other kids and adults do. Yeah.
Thanks for a great talk. This is a question, I know we're talking about what are just wondering if you've looked at the characteristics of the kids that show anxiety and those that don't. And with that in mind, for those of us with younger children, is there anything we can sort of set up in their environment or the way that we kind of, structure their lives to reduce the chances of significant anxiety, like, having them used to multiple caregivers and things like that?
Sorry, the last bit of your question, you said like...
So if we... is there anything we can do to reduce the chances of anxiety in our kids? If we've got younger children now that don't display anxiety at this stage, is there anything we can do, such as having multiple caregivers that our children are used to, those kinds of things?
Yeah, that's a really nice question. I think we're talking a lot about medications up here, but I am a firm believer that the behavioral piece of this is really important. I really do like to collaborate with someone in that way. And I think that one thing that I've seen families do a lot of is think about including variation in the schedule for their loved one with Angelman. Because oftentimes the changes in routine can be a major stressor. And I think about with treatments for anxiety in kids particularly, there's oftentimes a recommendation to do some amount of the thing that makes you anxious in a way that is still tolerable and realistic. And this is the extent to which behavioral therapy can play a major role in the treatment of anxiety. So if there's a fear around there being a change in the routine, having a plan for there to be some amount of change in the routine in a small way as a part of the plan. If there's a fear around anxiety or separating at night, a small amount of that. and thinking about that and starting that early for kids with Angelman. I think there is a natural desire as a parent to want to protect people from anxiety, and to arrange everything in the schedule that you can to avoid things that bring up anxiety, and that's a good thing to do, but there should also be, I think, a extent to which for a parent of a person with anxiety, they're trying to find little ways to challenge, and so that's what I think about with your question. I don't know if that answers your question.
Yeah, I think you did.
Yeah.
So my son's 5, and I don't think at this time he's exhibiting any anxiety, but I feel like there's so much mind reading or attempts at mind reading with our kids. He does bite his nails, but I don't know if that's like a sensory thing so could you just talk about, and I know every child is different, but just kind of the general trajectory you see in Angelman children's heading into adulthood and how anxiety can manifest itself, so I can or as parents, we can be looking for anxiety signs and symptoms in our kids, because, if it's a new behavior, well, is this a sensory deal or is this anxiety? So what are some of the behaviors that you typically see in your clinic that parents are bringing their kids in for treatment? And then I guess my other question was, what non-pharmacological interventions can we be doing if we start noticing, and I guess you kind of answered that a little bit with the last question. So what should we be looking for as parents and caregivers?
So that's a really excellent question. It is, I will say that part of the reason what we're doing with the study is that we are looking to really compile. I think one of the things you really get as a clinician working with with people with a specific condition is you become a repository for all the knowledge that parents have passed on that you can then continue to disseminate and share. So I have some of my own senses of how it's manifested, and I'm sure you will too, Ron. There is an extent to which we will have more information for you on this when we complete the study, and I'm reluctant to put too much of saying, here's what I want you to tell us in terms of the study. But one of the major things I see that come out is separation, which I think is probably, I don't think I've maybe seen many people with Angelman who didn't have at least a small amount of that, but I've seen ways in which it is extraordinarily intense and hijacks the life of the whole family. And that is probably one of the more common things that I've seen.
And so would that be manifested in like tantruming, if like the preferred care providers going somewhere, you'd see tantruming in that instance? Like, is that typically how separation anxiety manifests in our kids?
Yeah, and sometimes it's even like they're at home and they're so focused on one parent that the other parent can't talk to them or do anything, and if that one parent leaves, it can be impressive. And kind of like what I was saying in the beginning, it can manifest in so many different ways. It's hard. But kind of brings up another interesting point. Like the folks that see Chris, the folks that see Logan, they're seeing a psychiatrist for a reason. So they're all going to have something going on. That's why they got there. But for someone like me that just kind of sees everybody, and when we talk to families ahead of time and we're planning their clinic visit, if they say, yeah, we need to see a psychiatrist, then we know they need to see a psychiatrist. But if they don't think they do, and then we see them, we find that some do, and we say, this is anxiety, this is what's going on, this is something else. And then we send them over, and then some people don't, even though anxiety is a huge thing, and it's probably there. We all have it, and I think kids with Angelman have more. Kids and adults with Angelman have more, but it becomes when you refer to a psychiatrist and when you start treating it, it's when it interferes with quality of life. There's a lot of people with Angelman syndrome that they're a little bit anxious, but it's not a big deal. It doesn't affect doing this, doing that. They go to their therapies, they're hanging out with their family, it's all fine. And if that's the case, you don't need to treat it. Even if you see little glimpses of anxiety, if it's not changing your life, it's not a big deal. It's when it starts to interfere with your therapy and going to school and going to the doctors and being separated from a parent. That's when it needs to be addressed. So it's probably there in everybody, but it doesn't need to be treated in everybody.
Not necessarily.
Yeah,
okay.
if that makes sense.
That's nice, Ron. I hope that we'll be able to have a better answer for your questions.
Yeah.
What can the future hold? What are the things I need to watch out for? It's a big portion of the study we're doing. A lot, I would say I don't know the answer to your question, but I think it's an important one, and I'm glad that there's a big move among research and Angelman to try and answer your question. I hope I'll have better answers for you in a year or two.
Okay, I'll watch for that. All right, thank you.
Hello, well, thank you for your talk. My question is from the Argentinian Angelman Association. It's not only mine. The first question is, if is the mouthing behavior or eating perhaps very important in this population? It's always important in anxiety disorder, but perhaps in these kids it's especially important the eating, increasing appetite and eating everything, or going to the mouth a lot of things. So I think that you didn't mention that behavior, and I think that it's very important to underline this behavior. And the second question is if you know if there is any relationship between alternative communicative system and anxiety, if one is improve the other, or is doesn't have any relationship.
So the first question is a great point. That came up in the last section on GI, and with pica, it's really tough. And there is with mouthing behaviors, it's hard too, because you can have mouthing behaviors because you're teething. You can have them. Kids with bad reflux will just chew and chew, because when you chew, it signals your saliva glands to make saliva, and then that coats your throat. So a lot of kids will just chew and chew to help the reflex symptoms. But in a lot of cases, it's anxiety or it's sensory, and so it's not always clear why they're mouthing. But it's it's probably more often anxiety than anything else. But it's not always anxiety. It could be reflux. It could be, and then with pica, it seems like to treat it really well, you really need behavior and GI, because there's a component of both to pica. For those of you that pica is when you eat things that aren't actually food, and some people do it because they're just having terrible reflux and their GI system's a mess. They just keep stuffing things in their mouth. But there's also it can also be from anxiety, from obsessive type behaviors, and often it's a combination. So if you're just only seeing a psychiatrist for pica, it's not always going to get better. If you're only seeing a GI person, it's not going to get better. If you see both, that's when you can kind of hit it from both ends.
Yeah, absolutely. Oftentimes with a behavioral consultant also involved, because it can be such a dangerous behavior if it does result in swallowing. A major concern, really limit the educational opportunities, because you need to be in a much more restrictive environment in terms of education, or it require a family member to be with them 100% of the time. It's such an important point that you brought up. And so I would probably say, in addition to GI and psychiatry, behavioral therapist as well, and a good team of people. In terms of what drives the behavior, your points were Ron, I might add as well, I wonder whether it's a stereotype repetitive behavior in some ways, separate from an emotional sort of anxiety, self-soothing, or a GI symptom as well. So while I think it's a very different condition than autism, I believe they're very, very different conditions. There are certain behaviors in terms of stereotype repetitive behaviors that can be seen across developmental disorders, so I wonder sometimes to what extent that drives it. Are certain stereotype repetitive behaviors seen more in Angelman? That's part of what the study is looking at. And excuse my error on the Argentinian, I apologize.
Okay. And the communication system, do you have any alternative communication system? Could be a good treatment for anxiety?
Yeah, thank you. I've certainly seen it help. Absolutely. One of the things we're doing in the study is we're asking about non-medication treatments and whether they've been helpful. And we'll ask about AAC therapy, alternative augmented communication, and to what extent that's been helpful.
Yeah, one of the best ways to treat behavior is enhancing communication, because it's a huge source of frustration. And
asking for a break.
Yeah.
Okay, thank you.
Thank you. Thank you.
Hi. In terms of measuring anxiety, you had mentioned the certain physiological responses that there are to anxiety, like an increased heart rate, shallower breathing, skin getting warmer, sweaty palms or whatever. I'm curious if, with all the advances that are happening in the wearables market with Fitbits and even like I've got a little pocket EKG on my phone, is there anything that might be useful within that to measure anxiety in Angelman population?
I think this is a great idea. There's been research on this in the autism world, looking at wearing something that measures skin conductance, that measures heart rate on a regular basis to see if it correlates with anxiety-provoking situations in populations with autism who are nonverbal. I'm not aware of that study being done in Angelman, but I think it absolutely should. I think it'd be very helpful. And would get at it. While it's kind of more of a broad thing, it may pick up anger too, or frustration as a separate thing from anxiety. I think it would be enormously helpful. You can see a way in which that may help schools or families as well get a sense whether somebody is upset. It's in the experience of working with people with Angelman, the people can be quite expressive. So you can see it in their face in a way that you might not with somebody with autism.
Yeah.
But to me, it seems like a great idea.
Thank you.
Thank you.
I really appreciate you mentioning communication, because that's what I was waiting to hear that. I think it's really important for us to be, as parents, making sure that our kids have access to ways that they can talk with us about what's going on, how they're feeling. So thanks for lifting that up. The other thing that we found, my son is 5, and we saw an increase in anxiety and aggression last year at summer camp, and ended up starting CBD oil as a treatment, and saw a reduction in his overall anxiety and aggression as a result of that. So I'm curious if you've seen other instances of that as sort of one of the treatments.
Yeah. You said that you saw a decrease in aggression with it?
An increase in aggression and anxiety where he previously didn't have any as a result of a pretty unstructured, unroutine camp, and then CBD oil really has helped with that.
Yeah, no, it's a great question. So that comes up a lot, the CBD oil, and it's one of those things where there's just not a lot of data so far. There's been one kind of larger trial for seizures. It was a drug company's sponsored trial, and it had good results. The early results that came out showed that it was as good or maybe a tiny bit better for seizures than most typical seizure meds. When the Charlotte's Web thing came out, people thought it was going to cure everybody, and it doesn't, but it's at least an option like Keppra would be or clobazam would be. In terms of if it helps sleep or anxiety, it's just nobody knows. It hasn't really been studied. Anecdotally, there's been a lot of families that have said that it does, and it wouldn't surprise me at all if it does. It's just one of those things that right now it's so new we don't know, but that the fact that we don't know doesn't mean that it doesn't help. It really wouldn't surprise me at all if it's helpful for that. So as of right now, we can't say one way or another because we don't have the data, but we have had several families say that it helped, and so right now all we have is kind of that anecdotal evidence, but I'm sure that as it gets easier to obtain, and ideally if someday the FDA approves it, then we'll really be able to know lots of things about it. But as of now, I think the best way to say it is it's promising, but we don't know, but it's promising.
Yeah, it's one of the things we're asking about, not consistently, but families are telling us about in terms of when we ask about previous treatments, we're asking about supplements, and that is one thing that's definitely coming out. So often I thought about putting it as a slide in my presentation, because I just completely anticipated that someone would bring it up, because that's just been my experience so much that people are telling me varying things about it and that they're trying it.
Hi. I have a 29-year-old son, and we had a care provider for about 2 years and lost her. And now all of a sudden he's starting to try to bite me. He gets real agitated and will try to lean into me to hug me, and he'll try to bite me. And this is a whole new behavior. And I don't know if it's because we've lost our care provider and it's his way of acting out.
That's actually a really big trigger that we've seen in a lot of adults is a change in care provider. They really get attached to people, and then when they move on to, especially if people are like doing it between, school and something else, and they move on, and we've seen people really, it's changing routine, and that can be a big trigger. So kind of like we were talking about with the GI stuff before, whenever something changes, like things really shouldn't change dramatically, just randomly. So whenever something changes, there's usually a reason, and it could be when behaviors pick up. It could be poor sleep, it could be constipation, it could be seizures increasing, it could be anything kind of more in that realm. But it can also be a change in caregiver, like I was mentioned before, a divorce. It could be a sibling moving away, going to college. So any life change can be a big trigger for that. And since a lot of people can't express that as well as they should, and hopefully that's going to get better over time. That's how it's often expressed, is through biting and hitting, and it's kind of understanding that doesn't make it easier to fix. It's still a hard thing to deal with. But changing routine is a huge reason for behavior to escalate.
Okay.
Yeah. And I think we have time for one more, maybe? Yeah, so one more.
Okay, so practically speaking, with children with Angelman syndrome, what do you want families talking about with providers around anxiety right now? I mean, I know you're doing the study, but what's something we should be talking about? Is there a simple protocol or just even a good question as a conversation starter about it? And then I'm a research scientist focused on holistic communication interventions. We've done some with functional communication training where you replace the challenging behavior with communication that meets the same need or function. What do you want us to know as researchers doing studies in communication? There's a few of us here. Is there some anxiety tool we could embed in our studies that would be helpful for you all in the future that we could know now?
Yeah, it's a nice question.
Yeah,
Let's see. I think, well, I guess, like I said in the presentation, there's not really a whole lot prior to Dr. Wink or Dr. Larson's article, really not a lot in terms of anxiety. So even clinicians who have an expertise in Angelman syndrome may not be thinking to ask about anxiety or bringing it up. Yeah. This, like you said, Ron, seems to be something that's more relatively new, probably driven by a lot of families bringing it up. So it is not necessarily going to be something that a clinician may ask about in an interview when they're asking about management of seizures and management of myoclonus and even management of aggression. It may not come up to talk about anxiety. So I'd encourage families, if they have that concern, to bring it up. I think for researchers and clinicians, it seems to me you've got such a good background in this because you look at what are the precipitants prior to an upset period. And there's been some good research that's done with behavioral therapists looking at aggressive episodes and what were the precipitants that came before it that led to the behavior. So I think that's I'm hoping that it's a trend that will continue in research in Angelman syndrome on behavioral issues. What were the precipitants that came before a behavior?
Are there any brief protocols from, say, the Fragile X work or anything that you could suggest as like a checklist? Not yet.
I mean, the ADAMS is
talk to you guys after your study.
Yeah, ADAMS is an assessment tool. That's the one that gets ended up using the most. I think it's nice in some ways, and in other ways it's a challenge because it doesn't get at all types of anxiety. But it's great for there to be a lot of different clinicians using the same tool because then you can put together meta-analyses combining data, and then you go from my 80 to 100 person subject to a study of 400 because there have been 4 different studies using the ADAMS. So I like that tool, although I think it's still imperfect.
Okay. So what I heard, though, is that if we can harness some of this description of behavior and looking at antecedent behavior consequence, if we can pull some of that out in our work, that could be useful. And then this ADAMS, and then for families to just speak about it, just dialogue is a good starting place. Thank you.
Absolutely. Thank you.
Yeah. And is it? Give a quick one.
Okay. My daughter is UPD, so I'm thinking because that my daughter has a lot of behavior, or I'm not sure it's anxiety. Sometimes she get bald spot in her head, and she gets this white stuff on her head, and it's hard. And the doctor told us because that is due to anxiety. And so we have to put the oil in, tease it out, and then take that out. And when she starts school, she gets more all over her head, and she scratches. And she scratches her back. She has scars on her back, all over right here. And then she get cuts, and she bangs her head, and we're like, oh, that must have hurt. And then she'll grab something and just hit her head. So I'm not sure is it just behavior or anxiety? So I get really confused.
Yeah, it strikes me that one of the reasons why I like to work with behavioral therapists involved is that they can spend time with an individual at school and look at what are the consistent precipitants that come up in school, spend 2 hours observing a loved one in school, and getting a sense of what are the triggers that lead to aggressive behaviors. I definitely think you should be thinking about anxiety as a potential cause. It's one of a range of different possibilities: poor frustration tolerance, a desire to get the attention of a preferred teacher or a preferred caregiver, physical pain of some kind. There are a lot of different precipitants that can come behind aggression. Like I said before, even just a rough expression of affection, or that doesn't really sound like it fits for your child that you're talking about. But in my mind, having a consultation with a behaviorist who can spend time with a loved one and observe in the moment can do what's called a functional behavioral analysis of an aggressive behavior or a self-injurious behavior, and to get a sense of what they think might be addressing it. You also want to make sure, Ron will probably bring this up, that you're thinking about underlying medical causes, reflux, which Ron brought up already, other underlying medical causes that may be bringing it up: headaches, migraines, seasonal allergies, dental problems. So those are some of the thoughts that come up, but in terms of your question, could it be anxiety related? Yeah, it's possible that it could be to escape an anxiety provoking situation.
Thank you.
Thank you all very much.